ചേട്ടൻ, സാജിദത്ത, റിജോ സാറ്,
Lakshmi.
Mary, we can hear you.
Okay, one minute. I'll just say, hello, Lakshmi. Hello. Or
You are audible, Mary. Good evening, all. Its time is 3:30. We are waiting for 2 more minutes for the participants to join. Okay, we begin the program. Good evening, one and all. On behalf of the Nutrition Society of India, Bangalore chapter, I, Dr. Sundaravalli, convener of the chapter, takes immense pleasure in welcoming all the participants who have joined virtually to the webinar series organized to commemorate the World Breastfeeding Week 2020. The theme of the World Breastfeeding Week is Support Breastfeeding for a Healthier Planet. The theme of our webinar series is First 1,000 Days of Life. Journey of the first 1,000 days foundation is very, very important for a better and brighter future. The first 1,000 days are a period of rapid physical growth and accelerated mental development and offers a unique opportunity to build lifelong health and intelligence. This refers to the period that begins with pregnancy, planning, and goes up to when the child reaches her second birthday. Each day of this journey is special and influences the way she develops, grows, and learns, not just now, but for her entire life. Especially first 6 months of excluding breastfeeding plays a pivotal role in growth and development of the child. Rashtriya Bal Swasthya Karyakram, Ministry of Health and Family Welfare, Government of India, in April 2018, brought a guide for every parent to have access to the information to create an optimal environment during the first 1,000 days for a better tomorrow. So for these 5 days, starting from today, 3rd August till 7th August, we have speakers with rich knowledge, sharing their expertise. So be with us on all 5 days to gain and enrich your learning and knowledge. With this, I request Ms. Mary Reggie, Assistant Professor, Department of Nutrition and Dietetics, Mount Carmel College, and co-convener of NSI Bangalore chapter, to moderate today's session and introduce our first speaker of webinar series, Dr. Pratibha Dwarkanath, who is going to set the tone with her talk on First 1,000 Days of Life, a Journey. Welcome you all. Over to Ms. Mary Reggie.
Thank you, Dr. Sundravalli. Lakshmi, am I audible?
Yes, ma'am. Yes.
Good afternoon to all the participants who have joined us for this webinar series. Let me start with a few words of the etiquette to be followed during the webinar. Kindly mute your audio and disable your video, which will help us to maintain the bandwidth. Your chat box will be active during the lecture and request you to post your questions in the chat box. Feedback form will only be shared after the question and answer session. So we request you to remain till the end of the webinar. I take great pleasure to introduce the first speaker for this webinar series, none other than Dr. Pratibha. Dr. Pratibha is an associate professor at the Division of Nutrition, St. John's Research Institute, Bangalore, India. She started her journey at St. John's as a senior research fellow, lecturer, assistant professor from 2001 and now an associate professor. She also served as a research assistant at the KEM Hospital, Pune, for 2 years before joining St. John's. Pratibha completed her master's degree in health sciences from the University of Pune and has been awarded her doctoral degree in public health from Curtin University, Perth, Western Australia. Pratibha is also recognized as a member of national and international professional bodies. She's a member of the Task Force, Human Development and Disease Biology, Maternal and Child Program, and Nutrition Society of India. She's also a member of the Healthy Birth Control and Development Knowledge Integration India, an extension of the Bill and Melinda Gates Foundation. She's a recognized PhD guide in food science and nutrition at the University of Mysore and Manipal Academy of Higher Education at Manipal. Dr. Dwarkanath has bagged a number of national and international awards. She has won the Young Scientist Award, NSI Prize, Ramanathan Award during the NSI conferences held in the years 17, 15, 12, 11, 9, and 7. She received the Best Poster Award at the 7th Congress of the International Society for the Study of Fatty Acids and Lipids at Queensland. Her oral presentation on leucine kinetics during pregnancy was awarded the International Travel Award, Bangkok. Pratibha is passionate about her work, particularly in understanding why Indian babies are born small, and has conducted a number of studies from observational, interventional to physiological and molecular approaches in the field of maternal and child health, focusing on the first 1,000 days of life. She has to her credit 50 publications in national and international peer-reviewed journals and has also contributed to a chapter in the book L-arginine Prediction During Pregnancy. It is a Springer International publication. Currently, she is conducting a large clinical trial of 11,000 pregnant women in Bangalore entitled Demonstrating Non-Inferiority of a Lower Dose 500 milligrams calcium supplementation during pregnancy for reducing preeclampsia and neonatal outcomes. She is also the PI of the international grants with King's College London entitled Oral Vitamin D Supplementation as a Safe, Affordable Treatment for Profound Vitamin D Deficiency in Pregnancy. And with DBT and NIH, she has her study entitled Distinguishing Features of Immune Signatures of BCG Vaccination in Infants and Revaccination in Adolescents in Bangalore, India. She has also recently successfully completed studies funded by the Grand Challenges Canada for her innovative scientific research work on iron-fortified biscuits during pregnancy. Her research has also contributed to news media. To name a few of her news media publications are research tasty iron biscuits for Indian women to take on anemia, a study that finds lack of vitamin B12 that may trigger low birth weight, and iron overdose in non-anemic women that can affect pregnancy. Ma'am, we are extremely privileged to have you as the first speaker for the webinar series. Thank you for giving your consent and accommodating your schedule to spend time with us through this lecture. Once again, on behalf of NSI Bangalore chapter, I welcome you, ma'am. Over to Dr. Pratibha.
Good afternoon to all. Am I audible?
Yes.
Yes, ma'am. Yes.
Pratibha, can you can you put it in the screen presentation mode?
Yeah.
Yes.
Thank you, Dr. Mary, for the kind introduction. And I thank the Nutrition Society of India, Bangalore chapter, and the organizing committee for giving me this opportunity to share my views and thoughts on first 1,000 days of life on the eve of Breastfeeding Week. In the present webinar series on imperative first 1,000 days of life, I present my views and thoughts on this. While there is tremendous work being conducted in this area, in the interest of time, I showcase few findings from the St. John's cohort conducted at the Division of Nutrition, St. John's Research Institute. The first 1,000 days of life. The topic covered will be the importance of these first 1,000 days, few modifiable maternal determinants that leads to adverse pregnancy and birth outcomes, along with findings of St. John's cohort. This is a very well-known slide describing the first 1,000 days of life, which comprises of 270 days of pregnancy and 365 days of first year birth and the second year birthday of the baby to make it to 1,000 days. This period is important because the growth from conception to 2 years represents critical window of opportunities to shape healthier and more prosperous futures. The right nutrition during this time has a profound impact on the child's ability to grow, learn, and thrive. It is also well known that the development origins of adult diseases starts right from the utero time period. This is a vicious cycle which most of us know and have been looking at from the school days. The vicious malnutrition cycle. Poor nutrition throughout life cycle is known because if a girl baby is born low birth weight, eventually in situation of deprived nutrition, tends to remain low BMI and also tends to gain low weight during pregnancy and eventually gives rise to a low birth weight. In the due course of this pregnancy or the life cycle, the baby or the woman, adolescent, faces a lot of other morbidity and hence the malnutrition plays a very important role. We will know that 1 in 3 baby, that is 30% of our babies, are born low birth weight. And almost 10 to 12% are born preterm, that is, they are born before the term, which is all a public health priority. Infants born low birth weight or preterm face a dual burden, not only at the time of delivery, but also at birth as well as further in life. In addition, one thing we cannot avoid talking about is the maternal morbidity that exists during pregnancy, which could be anemia, pregnancy with hypertension, gestational diabetes, infections, and many more. And why are we so worried about this? Because in India, there's a routine antenatal care practice in every hospital. The national guidelines warrants every woman to have at least 4 to 5 routine care with clinical examination and supplementation programs. So in those lines, morbidities are not restricted only to the women of the developing country, but it is seen that even the women of the developed country face this problem. Therefore, WHO has laid few global targets, reducing stunting in under 5 children by 40%, to decrease anemia in women of reproductive age by 50%. I spoke about low birth weight to reduce it by almost 30%, and encourage women to exclusively breastfeed in the first 6 months of life. The other burden of the childhood malnutrition is also obesity and overweight, and try to encourage that people do not have this side of the bell shape, but have a healthy weight, and of all also reduce the childhood wasting. On those lines, let me get back to malnutrition during pregnancy. If you see to the left and the right side of this diagram, you can see that the host of maternal infections and the morbidity that women can face due to the malnutrition. It could be anemia, it could be different kind of allergies, insulin resistance, hypertension disorders, and many more complications. On the other hand, the infant at birth could also have birth defects. It could be born preterm, maybe intrauterine growth restricted, may have neonatal complications, and of all, cognition and behavioral discomforts as well. In long term, if you look at the top and the bottom side, it gives us the long-term adverse events for the baby as well as the mother. Moving forward, let us then look at what happens when there's a malnutrition at any specific trimester in terms of exposed to fetal development at birth on the birth weight and the baby proportions, continuing to wait at 1 year and following the adult life. If there's an insult in the first trimester, it is well known that the downregulation of growth happens, reducing the birth weight. The birth proportion or the baby proportions are small, and hence there's a whole lot of cascade of events leading to non-communicable diseases in adult life.
Excuse me, Dr. Pratibha.
Yes.
See, your voice is echoing. Is the fan switched on, or can you speak directly to the mic, because it is echoing and we are getting from the participants that it is not clear.
Is this clear now?
It is better. Can you talk louder and a little more clearer, because I think the voice is getting diffused. No, we can't hear you.
Hello?
Now it is better.
Better.
Is this better?
Yeah,
Yes,
it's
yes. Thank you, ma'am.
Is this clear now?
Yes, now it's very clear.
Yeah. So moving forward to the second trimester, an insult in reduced nutrition may have a disturbed feto-placental relationships, may have a cascade of events leading to reduced birth weight, baby proportions will be abnormal, and hence, again, leading to non-communicable diseases such as NIDDMs and hypertensive disorders. Similar effects can be seen in the third trimester, aggravated by the brain growth development. It could also lead to growth hormone resistance or deficiency, and hence may lead to, again, a lot of problems. So this indicates that the insult during uterus period plays a profound impact not only at birth, but also in adult life. So now let us look at what have we done at St. John's. We started a study to perform a prospective observational cohort among pregnant women in urban South India, designed to establish the baseline nutritional and maternal neonatal health outcomes, particularly to correlate the critical health outcomes with the measures of maternal nutritional status. The specific objectives were to look at the maternal modifiable parameters, which are determining the risk factors of low birth weight and IUGR. As we know, there are various determinants of birth outcomes, leading from distal causes, proximal causes, not nutritional, maternal physiology, as well as placenta and the birth outcomes. I take this opportunity to talk about few proximal causes and few maternal physiology, walking through a bit of placenta and the birth outcomes. So let's talk about a very important aspect called the weight gain. We all know that the weight gain comprises of maternal and the fetus. And as from the knowledge, we know that an Indian woman weighing approximately 45 kilos tends to put on around 10 to 12 kilos. Of course, this is all based on her physical activity as well as the demography from where she begins, maybe rural area or the urban. While we talk about malnutrition and weight gain, along with other morbidities such as anemia and deficiency of macro and micronutrient, the effect on the birth outcome increases many foods. So now let us look at what are the nutrients and the food groups that generally play an important role. These run in large numbers. However, as part of the nutrition guidelines for pregnancy, folic acid, iron, and calcium are the supplementary programs essential for a perfect growth during pregnancy. However, there are two more things which cannot be avoided, the vitamin B12 and vitamin D. Therefore, in this project or in this study, I would like to take around few of these micronutrients in detail. And since we cannot talk nutrients in isolation, I also talk about food groups such as milk and milk products, their effects on maternal and birth outcomes. So let's take an example of maternal B12 during pregnancy and birth weight. We saw that mothers who had low vitamin B12 intake also had low vitamin B12 status during pregnancy. Further, the women who had low vitamin B12 status also had babies born with low vitamin B12 status as assessed through cord blood. It was also observed that women who had low vitamin B12 status had higher risk of having an IUGR baby. So what would this indicate as? Does vitamin B12 have a direct role in determining birth outcome? Or is there any other angle to this association, which could be, especially when vegetarian diet is performed? Or is vitamin B12 related to any other nutrient, maybe folic acid? Or is vitamin B12 a biomarker of a protein, maybe milk or so? Or in general, vitamin B12 has an important role to play in the methionine cycle. So we looked at a couple of food groups, especially milk and milk intake. We looked at milk protein as well as vitamin B12 independently with association of birth weight. It was observed that in the first and second trimester of pregnancy, the women who had almost 500 grams of milk per day had a higher birth weight as compared to those who had low milk intake. Similar effect was also seen with milk product and vitamin B12 intake, indicating that those women who had low milk protein or vitamin B12 had higher chance or odds of delivering an IUGR baby. Furthermore, it was seen that milk protein had a direct effect on gestational weight gain. It also had a direct effect on the birth weight. Somebody is raising hand, what it is. However, vitamin B12 showed a good relationship with birth weight. The question again comes in, is vitamin B12 related to any other nutrient, a biomarker of protein, or again having an important role in methionine cycle? Moving on to understand. Moving on, we also felt that vitamin B12 cannot be spoken in isolation. So we looked at the ratios of folate and B12. It was observed that high folate and low B12 intake during pregnancy was associated for small for gestational age babies. This is very important in terms when you talk about a methionine cycle. Therefore, we move forward to understand how does a methionine cycle pathway affected, especially transmethylation, transsulfuration, and remethylation using stable isotopic methods. To briefly talk about isotopes of an element, what are stable isotopes? These are the elements having the same number of protons in the nucleus, but different atomic mass. Stable isotopes are not radioactive and pose no radiation hazards. They are naturally present in the environment, including our bodies, in quantities known as a natural abundance. So stable isotopes can be used during pregnancy, in lactating women, children, and are also suitable for all ages. And of all, it is a non-invasive method. Therefore, we used 113C2H3 methionine labeled infused in these pregnant mothers to understand the methionine cycle. It was observed that vitamin B12 along with balanced protein energy supplementation was critical for optimal functioning of the methionine cycle in the third trimester. In these women who had low serum vitamin B12 in early pregnancy. Further, let's take another example of iron. The prevalence of anemia is high in India. Almost 50 to 60% of pregnant moms are anemic. Indian antenatal care mandates folate supplements of almost 100 mg of elemental iron and 0.5 mg of folic acid from first trimester onwards for at least 100 days. However, what happens in the situation where women are already with adequate hemoglobin or they are in the normal range? It was observed that the mean gestational age at birth and the birth weight significantly reduced in those who had high HB levels, indicating that high iron intake during pregnancy may potentially adverse the women to start their pregnancy with a normal hemoglobin by increasing the risk of low birth weight. So this gives us another question. Does iron supplementation be a targeted one, individualized? So there are a lot of questions that arise in understanding the role of each nutrient during pregnancy and how it can affect the mother, the baby in utero, as well as at birth. Moving forward, again using the tracer kinetic studies, we wanted to understand how does a mother meet the fetal requirements even though she may be a low BMI. We understand that the fetal energy demands are met from maternally supplied glucose. In fasted state, generally, the glucose supply is met by glycogenolysis and by gluconeogenesis. The gluconeogenesis is dependent on the endogenous protein breakdown from the mother. Well, it is also told that protein stores may be low in women who are low BMI. Therefore, it was important to understand how does a low BMI mother supply adequate energy to the growing fetus. I will not go into the details of the kinetics of the study, but just to get you a brief information that on infusing a uniformly labeled 13C glucose, we were able to understand the rate of appearance of that particular glucose in the mother. We were able to understand the CO2 given out by the mother and the baby as glucose oxidation. On the molar basis, this label can give us the rate of appearance of the total glucose oxidized. Further, we could also understand the four important parameters: the rate of appearance of this glucose, the gluconeogenesis, glycogenolysis, and the oxidation that gives energy to the baby. Therefore, it is important to understand how does a low BMI mother, when her rate of appearance of glucose is high, her glycogenolysis is high, and glucose oxidation is high, still able to give rise to a baby with appropriate birth weight or a good birth weight. And it was seen that It was all because the increased diet during pregnancy, which led to an increase in the gestational weight gain and hence had an increased birth weight. So all I want to tell you is that during pregnancy, the appropriate nutrition is vital for an appropriate growth and birth weight of the baby. As we have seen that at the time of delivery, after delivery, the placenta is thrown out. But this placenta, an organ or a tissue, has very potential to give us more insights of what happens during pregnancy. So if you look at the post-implementation, the decidual develops and acts as a selective barrier between the foreign fetus and the mom and follow a complex feto-maternal metabolic circuitry. So at the cellular and molecular level, the placenta can offer a historical record of insults and any counter reaction over the duration of the pregnancy. Therefore, placenta itself can give us leads to many of the pathways that are unanswered otherwise. So most of the people now say, do not discard the placenta with the birth water, but store it, it can give us more answers. This snapshot, although doesn't look very appealing, it gives you a morphological information of the placenta. You can see some bits being taken at different sites, maternal, fetal, cord, and a couple of the peripheral placental bits. And to the right, you can see the cord being cut. And just as an insertion of a cord on the placenta itself can talk a lot about the fate of the baby. Nowadays, a lot of gene expressions on the fresh placentae as well as a formalin fixed paraffin blocks placentae. And from our group, there have been a couple of genetic studies that have been done. And it gives a lot of information on how the baby birth rate can be modulated accordingly. So with this, I take forward another hormone or a nutrient of interest, and it is the vitamin D. I will not go into detail as to how do we get vitamin D, because we all know the main source of vitamin D is sunlight. However, it is also important to know that low vitamin D status during life has a profound impact, not only during infancy, at childhood, adult, as well as during elderly population, and with a whole range of morbidity that we can come across. So now let's look at what happens during pregnancy. As early as during the post-fertilization period, when the 3 germ layers are formed, the cells express vitamin D receptors, indicating that even before a woman knows that she's pregnant, the importance of vitamin D sets in, helps in organogenesis. It is also seen that modulations in the maternal vitamin D metabolite levels transfer to the placenta, and placental functioning determines the fetal vitamin D levels that you see in this picture. Vitamin D in fetus is important for skeletal development, as we know. Moreover, it is also observed that mothers who have low vitamin D during pregnancy translates into low infant vitamin D concentration 6 weeks postpartum, indicating that the effect of low vitamin D is not only during pregnancy or at birth, but has continued even at 6 weeks after delivery. So let me give you a brief information on what is a suggestion mechanism and why do we talk so much of vitamin D otherwise. It is known that vitamin D is associated with increased body fat deposition. Low bioavailability of vitamin D leads to increase in parathyroid hormone. It increases hunger and decreases energy expenditure. The low level of 125 dihydroxyvitamin D, the active form, may lead to decrease in lipolysis and increase in lipogenesis. Hence, it is thought that the obesity is a post-state of vitamin D deficiency. Therefore, most frequently question asked is, what if the baby is born with low vitamin D? Is there a relationship with adiposity at birth? And this leads to another set of question and experimental work. So we thought, let's look at the body composition of babies at birth. And the most commonly assessed is the skin fold thicknesses. And most of you know that skin fold thicknesses are measured by Harpenden or Halton calipers. And a set of computation could give us percent fat, fat mass, and fat-free mass. Various combinations such as sum of skin fold, central to skin fold ratio, and arm muscle area are also computed. We saw that maternal vitamin D in early pregnancy correlated with infant status at birth. But what was striking to see is that vitamin D in infants at birth correlated negatively with central to skin fold ratio, an index of centripetal fat stores. Is this a suggestive that infants born with low vitamin D levels may be associated with risk of increased centripetal fat store, a measure of fetal fatness? Therefore, further probing the role of vitamin D, especially in mom, early pregnancy with fetal fatness. I go forward to talk about another important nutrient, the calcium. There has been a lot of controversies on the calcium requirement during pregnancy. The guidelines talk about 1000 mg per day, while the World Health Organization and other funding agencies talk about 1500 to 2000 mg of calcium to be ingested per day, especially for those who have low intakes and at risk of morbidity such as pregnancy-induced hypertension. Let us look at what is the mechanism that could lead to an elevated blood pressure or lead to preterm births. Low dietary calcium increases the parathyroid hormone, which activates the release of ionized calcium in the serum. The ionized calcium binds to calmodulin in the smooth muscles and forms the complex which activates myosin kinase and enhances the contraction. The vascular smooth muscle contraction leads to elevated blood pressure, and if contraction is at the uterine muscle, leads to preterm births. On the other hand, similarly, if you have adequate calcium through diet, decreases the parathyroid hormone activity, thereby helps in reducing the blood pressure and help in reducing the preterm births. On those lines, let me showcase an interim analysis on the calcium intake during pregnancy. This table indicates that the percentage of PIH across tertiles of calcium intake, which includes dietary as well as supplemental calcium. The supplemental calcium is generally thought from second trimester, 14 weeks onwards until delivery. It was observed that the women who consumed low intake, that is called the lowest tertile, had higher percentages of PIH as compared to the ones who had high intake of calcium, that is the highest tertile. This was similar in the second as well as the third trimester of pregnancy. Similar observations were seen with preterm births as well. It showed that the women who had or who belonged to the lowest tertile of calcium intake had high percentage of preterm births as compared to the highest tertile of calcium intake, which means 10.2 versus 6.5 and 10.5 versus 8.1 in second and third trimester respectively. This being a breastfeeding week, I did not want to end my presentation without mentioning the breastfeeding information from the cohort. Although this topic of breastfeeding, growth, and development of infant will be dealt extensively in subsequent videos, I want to highlight that the interim analyses in the cohort showed almost 93% of the women breastfed their infants within 24 hours of delivery. However, only 45% of the women continued exclusive breastfeeding until 4 months of age. Why is this so important? Because there are evidences that talk about the allergic disorders. This is a very known prospective birth cohort that demonstrated that the children who were exclusively breastfed up to 4 months or more had low percentage of having asthma as compared to children who are breastfed for a shorter duration. Similarly, it was seen for other allergic disorders such as atopic dermatitis and allergic rhinitis. So let us see, what did we see or we observe in the St. John's cohort? We looked at the relationships of three things: wheeze-like symptoms, rhinitis, and eczema with birth outcomes in under 5 infants. The babies who are born SGA versus normal, that is AJ babies, were looked at for these kind of symptoms, and it was striking to see that the babies who were born small for gestational age had almost twice the risk of developing wheeze when compared to appropriate for gestational age babies. I found that this was little important to highlight because we all are in the midst of COVID-19 contagion that affects respiratory system and may even prove fatal. Hence, ensuring that the adverse birth outcomes such as low birth weight, SGA, are reduced, we may prevent severe respiratory infections during infancy. So I end up my talk today by saying that first 1,000 days of life are very important. They lay foundation for the future of these infants. Thank you.
Thank you, ma'am, for that extensive, detailed information, and especially from the research point of view. We really enjoyed the details that you have done, and because it is from a research institute, we are very happy that you have given us a lot of information from evidence base. So, ma'am, can we take the questions?
Sure.
You're muted. Lakshmi, can you hear me?
Yes,
Audible?
ma'am. Yes. It is audible.
Yeah, okay. Dr. Pratibha, can we ask you your questions?
Hello.
Yes, we can hear you, ma'am.
Volume. Yeah.
We would like to know, how did you assess the vitamin B12 intake from their food?
Yeah. So there are various dietary. Hello.
Yes, we can hear, ma'am.
Yeah. There are various dietary method assessments to understand the nutrient intake. So we used the RDAs, we used the ICMR calculations and the USDA to understand the intake of all these micronutrients and macronutrients in the food groups and the food that was ingested by the pregnant mothers.
So you weighed the foods and you assessed it, like a dietary recall?
Hello?
Like a 24-hour dietary recall?
These dietary methods were at 2 levels. We are not able to hear. We are not, just one moment. We are not able to, it's not getting connected.
Pratibha, kindly keep your phone away from you.
Yeah, so there are different, hello, am I audible now?
Yes.
Yeah, so there are different methods of dietary assessment. We have used 24-hour recall, which will give you a snapshot of the diet intake for the previous day. We have also used a food frequency questionnaire that gives you an indication of the food consumed in the previous 3 months of time period. So for each trimester, what the diet was consumed. We also validated the food frequency questionnaire against multiple 24-hour diet recall to understand how the intake worked during that particular trimester.
Okay, so that means you used a quantified food frequency questionnaire.
Absolutely.
Okay, thank you, ma'am. Next, we have another question. What are the physiological changes in children who were born to women with proper vitamin D intake and those children without?
So if you were to know that almost 90%, am I audible?
Yes.
Yeah. So it is known that almost 90% of our population is vitamin D deficit. So there have been very few studies looking at the vitamin D concentrations in children and its subsequent effects at growth. However, we all know that having a pivotal role of this vitamin D in skeletal growth, in bone development, and also in other physiological changes, people have observed that these children are growth retarded in terms of they do not have appropriate length or height for that particular age. However, there is lack of information to look at a causal effect of vitamin D with this.
Okay. Ma'am, the next question is, what about vitamin B12 intake among pregnant vegans? How did you assess?
Yes, that's a very good question. So basically, we know that most of our women are vegetarians. Even those who do not consume non-vegetarians are very few, but the quantity is still very less. We didn't have anybody as vegan in our population because we cater to low to middle class women. So the way it went is that look at the 24-hour recall and the FFQ for the dietary patterns. And what was observed is that since we did not have anybody exclusively vegan in this, we had most of them having vegetarian diet followed, which included at least milk and milk products.
Okay. Thank you, ma'am. The next question is there no significance of magnesium during pre and post pregnancy?
Evidences do suggest that magnesium plays a very vital role. However, in my study, I have not yet looked at it. And that's a good thing because as I always said that a nutrient cannot be looked in isolation. It will be nice to even look at the relationship with other macronutrients.
Correct. Correct. The next question, ma'am. What are your thoughts on prenatal vitamins and minerals given compulsorily to all pregnant women? Is it unwise to do so without appropriate diet history or investigations?
I would rather talk about individualizing the supplementation program. The national guidelines, what comes in now is to look at the broader spectrum of the population data. And that is why when you talk about any supplementation program in terms of iron, folic acid, or calcium, looks at what is the deficiency of the population in general. Now, when we talk about popping in a whole set or array of micronutrients, many of them will supersede the other and may have other deleterious effects.
Okay.
Therefore, it is important for us to have the mandatory ones in the light of the deficiency for the population and also try to generalize or have an individualized thing if need be. And that is, I think, one of the main reasons why even today, vitamin B12 also, there is so much of knowledge about the role of the deficiency. It hasn't been part of the routine care, although few of the physicians, OB-GYNs do suggest or do prescribe.
Okay. Thank you, ma'am. The next question is there any possibilities of transferring vitamin D deficiency sensitivity to child from the mother?
Yes. So I have already shown one of the speculations from my study was the mothers who were deficit of vitamin D in the first trimester had babies who also had vitamin D deficiency assist in the cord blood. This meant that there was a transfer of vitamin D to the baby in the similar fashion.
Okay. There is another question. You said deficiencies can lead to eczema. Can you give a brief on it?
Deficiency of, sorry, I didn't get your point.
Deficiency of vitamin B12 can lead to eczema. Can you give a brief on it?
I didn't talk about vitamin B12 with eczema.
You said deficiencies. No, she meant deficiencies can lead to eczema. Can you give a brief on it? About eczema?
The eczema was about the allergies that we would see. and I showed a relationship with regards to the babies who are born small for gestation age having a higher risk of allergies.
Okay.
And that was linked to breastfeeding.
Okay.
Because, yeah, so that was the slide on the 32, indicating that the children who were exclusive breastfed for 4 months or above had lower risk or had lower percentages of having asthma, atopic dermatitis, and rhinitis as compared to those who were breastfed for a shorter duration. And what we saw is that the babies who were small for gestation age, born earlier, and they had a higher risk of all these kind of things because they were also not even breastfed for appropriate time period.
Okay. What about your thoughts on magnesium intake in PIH? Do salt restrictions will be of any help in PIH?
There has been a lot of information going either ways about sodium restriction for pregnancy-induced hypertension, but sodium alone does not talk about it. It is about the calcium and magnesium interaction that plays a vital role in pathophysiology of PIH. So in general, just reducing a sodium content would not help. Rather, it would do lack of these nutrients may affect in other way.
Okay. Is it true that a pregnant woman eats high content of iron? Babies will get green patches on baby. That must be a very silly question. Okay, must be one of our students.
I get that point. I with due diligence with what is told, and I think it's more of a cultural or the thing that people just talk about it. This is not true. It's absolutely not correct. But there are a lot of myths around people talking about high iron intake and having dark babies or having high